Hello everyone, welcome to our latest webinar for SMA UK. It's been a little while since the last one. I hope everyone tuning in live or watching it later, you've all been keeping well and getting a chance to enjoy some of the recent warmer sunshine we've all been having. I'm very excited to be joined by our amazing health professionals today, and we're going to be talking about Zolgensma for SMA type 1 for babies. And we're going to have some general information that we're all looking forward to hearing, and then there'll be a chance for questions later. So whichever platform you're watching this on, you can type in the comments and that will come through, and we'll be able to share all the ones that we can get round to. And likewise, if the webinar is finished and you have questions, you can still get in touch with SMA UK, and we'll make sure we join all the dots for you afterwards as well. So it'd be great to get some introductions first of all. So Francesco, would you like to start off, and we'll go to Anne-Marie and Fiona, just a few sentences on who you are for everyone watching. If they don't already know you, I'm sure they do.
So I am Francesco Muntoni. I'm a pediatric neurologist. I work at the UCL Institute of Child Health and Great Ormond Street Hospital, and I have a long-standing interest in neuromuscular disorder and SMA in particular.
Thank you very much. Anne-Marie?
Hi, I'm Anne-Marie Childs. I'm one of the paediatric neurologists in Leeds, and I've been looking after the neuromuscular service for children there for about 20 years now, and have developed an increasing interest in SMA over that time as the landscape has changed dramatically and really excitingly for children, young people and adults with this condition.
Great, thank you. Fiona?
Hi, I'm Fiona Marley. I head up the highly specialised commissioning team at NHS England. I commission and plan services for patients with rare diseases and have been doing so for about the last 15 or so years. And I've been commissioning services for patients with SMA.
Great, thank you. Welcome all of you, and thanks for joining us on this webinar. So as we said, we're going to be focusing on Zolgensma. I think there may be one of the questions that we've already sourced from the community that may sort of touch upon in comparison to risdiplam and Spinraza. And as you were saying, Anne-Marie, it's an amazing last year or two. I know for me and my sort of getting into my late 30s now, for most of my life there was not really any major sign of treatments, and suddenly 3 are all come on the scene quite quickly. And I think the community are really just sort of trying to get our head round what the differences are, how to get more information, how to access the relevant ones. So I think, Francesco, we'll start with you. We're going to be looking at Zolgensma and how it works and the outcomes to date, and Anne-Marie and Fiona for any additional points afterwards as well.
Yes, so as you all are aware, in spinal muscular atrophy, there is not enough protein called SMN that is produced. So the scope of every treatment is to make more SMN protein produced. It needs really to be produced at least or mainly in the motor neurons in the spinal cord. So that, I think, is what you need to treat. And one of the therapies that have been developed is the Zolgensma is using this quite novel for the neuromuscular group of people, AAV gene therapy. And the AAV gene therapy use if you like, there is a lot of information now on how viruses can be modified to do what we want, not what they want. And an example is the AstraZeneca vaccination. But this particular AAV is not like the vaccination that is used for AstraZeneca. It's a slightly different virus. It's a virus that is present in the general population, but it does not cause infection. And in order to make it even less potentially problematic, is the way the gene therapy is done is by gutting really the virus by using the envelope as an empty envelope where we put what we want, that is in this case SMN. And what is interesting of this AAV, and this is why it's been chosen compared to other AAV, is that this is the only AAV that if you put in the vein after intravenous infusion, will be able to go and reach the brain and the motor neurons. So that, I think, is how, you know, the AAV is used to deliver the SMN to where is needed. Therefore, the clinical trials have been, most of the clinical trials have been done, early clinical trials have been done in the States, and they have been, you know, the original clinical trial that led to the FDA approval in type 1 SMA. This data have been published in the New England Journal of Medicine now several years ago. And this is called the START trial. And then there have been two parallel studies, one in the States and one in the Europe, regarding the in type 1 children with very similar but not identical clinical features, and really to compare the effect, the different degree of disease progression and age at treatment had on the outcome. And these are the STRIVE EU and STRIVE US study, and I am the investigator of the STRIVE US study. And finally, there is a pre-symptomatic clinical trial called SPRINT, where we also are involved, that is meant to treat children either coming from newborn screening or in whom a diagnosis was made in the first few weeks of life because they were the second sibling in a family where there had previously been an affected child. So that is also a study that is well underway. And maybe I should stop here because I just wanted to give a brief overview, but I'm happy to cover more questions if you or some of the people in the audience have specific questions.
That's great. Thank you, Francesco. And Anne-Marie, was there anything you'd like to add?
No, I think that's pretty comprehensive. I mean, I think that, I suppose the only thing to say is that whilst the first therapy was given, as Francesco mentioned, in the States several years ago, we haven't yet built up a huge knowledge and expertise about what the long-term effects of some of the gene therapy will be, because the children are only, I think the oldest child's maybe 4 or 5 years of age now. So there are still some questions that we all have about what this means in the longer term.
Great, thank you. And Fiona, do you have anything you want to add, or should we move on to the next part? Okay, I think you might be on mute there, Fiona, but we'll come to you.
Yes, very comprehensive. I didn't have anything to add. Thanks.
Great. So I think the next point was around potentially eligible children, which I think we were going to come to you for Fiona. So would you like to just speak around that point a little while?
Yep. So I know from discussions with the patient group that, it is quite complicated because the draft NICE guidance mentions some children, and also NHS England made an announcement about potentially other children who might be eligible. What we've been doing in NHS England, because we don't want to delay the start of the service, is that we've been working with clinical colleagues to actually set out what those clinical criteria might be, so that as soon as the service is able to start, that we're not starting from a blank page, and we know the sort of information that your referring clinicians will need to use to make a referral. We've got the various groups who are mentioned in the NICE draft guidance. So that's the pre-symptomatic children, those under 6 months, those aged 7 to 12 months, and then the ones that also are not mentioned in the NICE guidance, which NHS England mentioned, which are those older children, but who are still within the licence. And I guess it's particularly for some of those older children that those criteria will be particularly important. So what we've been doing is some pre-work so that when the service is ready to go, that we'll be able to provide that preparatory work to the 4 centres that are going to be able to offer the service. And I'm sure they might want to refine those criteria, but at least they won't be starting right from the beginning. The other thing that we're putting in place is something that we called a referral portal, which is like a sort of online way of collecting all that referral information in one place, so that those 4 centres can see that information and be able to work out and work with each other to decide who's eligible for treatment, and they can share all of that information. And that's a way of also making sure that the National MGT, which will have membership from all of those 4 centres, can make sure they've got all the relevant information in one place. So I think I will stop there for the time being and see if Anne-Marie or Francesco want to add anything.
Great, thank you. Anything to add?
I think maybe I would add a different concept, but this may be also of interest. Is also because I didn't cover this in my presentation of the Zolgensma. The treatment has been mostly at the moment trial in children with type 1 spinal muscular atrophy. With the exception that some of the pre-symptomatic children were eligible even if expected to develop type 2 SMA, and as you are aware is the copy number of SMN that determines the probability to develop type 1 or milder or more severe, type 2 SMA. There has not been treatment in people, in adults or in older individuals. There was a clinical trial for individuals with type 2 SMA who were older, but because there is an issue of the amount of virus that you can safely give to larger and bigger individuals, this particular clinical trial was done by giving the drug directly in the spinal fluid, let's call it in this way. But at the moment, the clinical trial is on hold, and therefore the reason why this is on hold is because there is the theoretical possibility from animal models of some toxicity that is not been observed in the human, but following maximum safety guidelines, that study has been reevaluated in terms of the risk benefit. So the point I'm making is that the experience really is internationally only with type 1 children, with the exception of the pre-symptomatic who may have had some children who were going otherwise to be expected to develop type 2 SMA. So that already gives you a sense that that's why I suppose the treatment at the moment will not be available for people who are, for adults or for people with milder forms of SMA, because they had never been studied using this particular route of administration.
Great, thank you. Anne-Marie, anything you'd like to add?
I mean, I think just really following up from what Fiona and Francesco said, I think, like all treatments, we've got there's an important responsibility to consider the risks and the benefits of treatment, and we're still learning about that, I think. I think for all of the treatments that we now have available for SMA, we understand that if they're given early as possible in the disease process before any irreversible damage has occurred to the nerves, and that's likely to yield the greatest benefits. And I think that one of the challenges for Zolgensma is this increased risk as the children become heavier and need an increasingly large viral load to deliver an effective treatment. And so that does mean that the risks of this treatment are really important to consider, because we know from experience from other clinical trials of gene therapy that there have been some really severe side effects and outcomes when we give that degree of viral load to a young child.
Great, thank you for that. I think when the next point was going to be around the infusion centres. I think Fiona was going to take that one. Anything you'd like to say around that?
Yep, so in terms of an update on that, we know that there's an enormous amount of interest in providing this service amongst all of the neuromuscular centres in England. So we've been running a process to identify those who are best placed to be able to offer that service. We have written out to the successful and unsuccessful centres on Monday that's just gone. That is currently confidential, so I'm afraid I can't tell you where those centres are, but that information will be public at the beginning of May. I think that's probably all I can say at the moment.
Okay, thank you. And I think the last point before we get to the sort of questions, that some of them have been sent in advance, and as I said earlier on, if you're watching now and you have some questions, start typing, and we'll definitely get around to them a bit later in the webinar. But it was around the treatment pathway. So it'd be great. I think that's for all of you. I don't know if anyone would want to dive in first, but yeah, just to talk around the treatment pathway would be really helpful.
I think I can start, and then I think that I think this is for all. I think the principle is that the treatment can be given as a single infusion, intravenous infusion, but the children will need to be followed for a period of time. I think Anne-Marie briefly alluded to this, to the fact that there are some adverse events that are relatively common, and these require monitoring with corticosteroids, and there are protocols to try to identify this, and therefore the treatment, the infusion center will also become, for a period of time, the main place where the care of these children will take place. But of course, with time and with the longer, in the longer term, the possibility to return the care or some of the care to the local center will be explored and finalized and finally discussed and agreed. I suppose the optimal model will be agreed together with NHS England and NICE at the time when the 4 centres will be declared, and they will be formed. I think maybe Fiona can say a little more. There will be probably, if you like, a national networking system and so on that will deal and with how exactly the pathway will work. But maybe either Fiona wants to take it from here, or Anne-Marie. But I suppose the point is that in the UK, we have been working in networks before. This will not be the first nor the last time.
Shall I just pick up a couple of those points then? So there'll be, as I mentioned before, there'll be a national multidisciplinary team who will have membership from the 4 centres. For some of the children, particularly those ones who were in the NICE draft guidance, it may be that one of those centres will go ahead and treat that child without reference to their colleagues in the national MDT. And then perhaps for some of the older children, that will absolutely benefit from discussion with the other 3 members of the MDT. There are some key tests that need to be carried out as part of the pathway, and I might get Anne-Marie or Francesco just to tell you about the test that has to happen with the virus, because that's particularly important. But there are some tests that need to be done before treatment. There's the treatment and then some monitoring afterwards. And one of the key points in picking an expert provider was to know that there was someone in their team who was going to make sure that all the relevant tests had happened so that treatment was given in a safe way. The company who produce the product are also going to be employing a couple of nurses to cover the country, who will also help to look after the families and to make sure that they get the tests at the right time as well. So we're just talking to the company about exactly how those individuals fit into the patient pathway. But I think that's something that's extremely positive to know that the company are also employing people so that we have a sort of wraparound service. But I wonder if Francesco or Anne-Marie could pick up the point about the viral test, because I think that's very important that people know about.
Well, Francesco's explained that the way in which we deliver the new replacement SMN gene is using this AAV9 virus. And whilst that isn't a virus that we think of as being a virus that causes pathology in people, it is around in the community, and some people do have antibodies to that virus. And that would mean that if we tried to give you a treatment that contained the virus, that the body's immune system would reject it and the treatment therefore wouldn't work. So testing an individual child or infant who might be suitable for gene therapy is going to be a very important part of the pathway. And I think that, I just would want to reassure people that, as Francesco says, we've been thinking about this as a network of SMA centres and how we are going to work with our colleagues, not just in other non-treatment centres, but also, working in mainstream hospitals in the community, so that there's very clear pathways where if there's a potential patient who could benefit, they can be rapidly referred into the system. It's also important that we check that the infants don't have any other illnesses that might make them more vulnerable to developing a severe side effect. So there are some other blood tests and screenings that would need to be done, looking at liver function tests, cardiac function tests. And we are thinking about at what point in the pathway that would take place, as well as making sure that the whole multidisciplinary network that is essential if we're going to support a child and family with SMA type 1 is in place. And so it's good to know that we've got the nurses who can help coordinate information transfer and keep information flowing and potentially support training. But it's also important that we build the right networks within the different treatment centres so that we can minimise the effect of geography or other factors in terms of who gets treatment when.
Great, thank you, everyone. That was very, very helpful and useful. I know, as always, I learn so much on these webinars, and it's very helpful for everyone else tuning in. So I think we've covered off the key points we were going to go through. So we're moving to the questions side. There were 5 questions that had been sent in to SMA UK in advance. So thank you to the people that had sent that in advance. So yeah, we've got question 1. If we feel we've actually covered any of the 5, we can skip over quite quickly, so no worries about that. But the first one is, if the treatment will not be available for children from outside the UK, will there be a possibility of having it done privately? If so, is the cost, at least the estimate, known?
So I'll have a go answering some of this in the first instance. So I guess it will be down to the 4 centres to decide whether or not they want to offer a private service. And I guess also, clearly we're very keen that all eligible patients on the NHS are the ones who are prioritised for treatment. And also to say, as you may have seen in the announcement from NHS England, we have been able to negotiate a special price with the company. And it would be for the company to decide. That's just for NHS patients. So it would be for the company to decide what they charge for people who are accessing the treatment privately. I don't know if Francesco or Anne-Marie want to add anything to that.
Not particularly. I mean, this is I think probably, I think as an important concept is that while the treatment is a simple treatment to give, because it's an intravenous injection, and even I can still remember how to do an intravenous injection. I think the infrastructure to be able to do this properly requires some thinking. So it's not something that could be given by any provider that can just access the vein of a child. And therefore, I think it's important to consider the capacity to be able to deliver this in a multidisciplinary setting and doing properly. So I think that at this point in time, to make sure that things are happen properly is probably more important than thinking what about patient outside the NHS.
Okay, thank you. Anne-Marie, anything you want to add, or should we move to the next?
No, I agree with that, really.
Yeah. Okay, great. So number 2, when do you think the centres will be set up and fully ready? When do you think it will actually be given to children?
So I'll start with this one. So in the letters that went out to the successful providers on Monday, we've asked them to confirm that they would be able to treat a child in May. So that's our aim. We've asked them to confirm that.
Okay, fantastic. That was a short and sweet answer. So hopefully things will be ready. Yeah. Anything else from Francesco and Marie? No. Great. We've gone to number 3. I would like to ask if Zolgensma will be available for children who are currently on Spinraza, and if there is an age limit cutoff.
Shall I start from I'll start and give a non-clinical answer because I'm not qualified to do that. Yes, so, all of the neuromuscular centres at the moment are very quick to get children on Spinraza and Risdiplam if they can't have Spinraza. So we fully expect that some of those children that the National MDT will assess will be on Spinraza. I think I might ask Francesco and Marie to talk about the age limit cutoff.
I mean, I think that age is difficult because it's really about the balance of overall risk and benefit to the treatment. And we talked about the greatest benefit being at the earliest time course of the disease. And I think, we know from our other treatment experience that those most severely affected are perhaps less likely to see the greatest benefit from treatment. But the priority is going to be to try and treat people who are going to benefit greatest as a priority. But I think that in terms of the age limit, I think that what we are thinking about is that balance between the risks and the benefit of the treatment. So it's not so much the age per se, it's about whether or not the risks of giving the treatment start to outweigh the likely benefits. And that's why it's going to be so important to have an expert clinical MDT that are looking at this across the whole of the community in England and Wales, so that we do our best to make sure that we've got a fair system to allow the children to get treatment on the basis of the likely benefits and the minimising the risks. So I think that age has been put in to a certain extent in the NICE criteria because that helps us I suppose focus our minds on early diagnosis and early translation from diagnosis into treatment. But the age in and of itself is not the be all and the end all. It's a bigger and more complicated picture than that.
Great. Francesco, anything to add?
Not really. I think that in a way is a bit like for many aspects of clinical trials, age defines one aspect, but then severity, comorbidities, and other aspect determines the remaining part. So age is one of the equation, but cannot be the only one. And that I think, as my colleagues mentioned, the role of the MDT will be to apply if you like, a criteria that can be both transparent but also applicable to children outside what an individual person decides.
The only other thing I would say is that, what we want to do is try and give children the best possible outcome, and that means trying to protect their nerve function as soon as possible. So, I think it's very likely in the basis of the question below that there will be some children because of practical reasons and because we're just beginning to start this therapy where there may be a longer gap than we'd like. And in those children, we would want them to have other drugs that would protect their nerve function. So I don't think that we would want to deny a child treatment with Spinraza if we felt that the possibility of them having treatment with Zolgensma was going to be such a time frame where potentially more problems could ensue. I perhaps haven't explained that very well, and maybe somebody could just make sure that makes sense.
The bottom line is starting treatment as soon as possible is probably a priority number one, whatever treatment, and then if the decision is to move into Spinraza, then to get it happening also as smooth as possible. But I think, as you indicated and Fiona has indicated, the process is starting. I think an important aspect is to consider that it will be impossible to treat on the day one every single child in the country, and therefore it will take a little of time. And the good news, I suppose, is there are system and drugs to buffer this period of time when the various centers will be up and running, and then there will be, of course, the impossibility to treat everybody. We are coming from the vaccination, a big success of the NHS by vaccinating, I think, maybe 35 million people but these people didn't have the vaccination all in one day.
Okay, we'll move on to number 4. Thank you for your answers to that one. Which hospitals will be centres for administering the treatment? I think, Fiona, you sort of really covered that earlier, didn't you, when we were talking before? So I think we can move on to number 5. Why do SMA type 3s always seem to be left out of treatment, like risdiplam and Zolgensma gene therapy? When will they be able to access these treatments? Anyone like to take that first?
I can start, but I cryptically addressed this before when I say, in reality, children with type 3 never receive this drug, and certainly not systemically, meaning in the veins. And I think that there are several problems if a child with type 3 was going to receive this. Firstly, there would be nobody who has received that particular drug intravenously at that age and so on. Secondly, I think there are some concerns that the amount that you need to give intravenously to reach the brain may cause substantial adverse event. And also, we do not know how effective it would be given in the veins. So the reality is that at this particular drug and in this particular mode of administration, it would not really be possible to give it to individuals with type 3 SMA. There is ongoing work that the company is doing to try to assess how safe it would be to give a drug like this one to people, including people with type 3 SMA, but if given directly via the spinal fluid.
Do you want me to talk about risdiplam?
That'd be great, thank you.
I mean, I think that there's a difference between the way in which we're able to deliver risdiplam at present, which is through the Early Access to Medicine scheme. And that's a scheme that the MRHA run when there is a perceived urgent unmet need. And we know that there are some young people and children who have not been able to receive Spinraza, and they have been able to be treated with risdiplam. But this is a different scheme to what might happen when risdiplam becomes a treatment that's approved by the NHS and goes through the NICE process, which, as you know, is an ongoing process, and that is considering the role of risdiplam that might have across the range of people with SMA. It's not just considering people with type 1 and type 2 SMA.
Thank you. Fiona, is there anything you'd like to add to that?
No.
Okay. I think there's a second part to the question. So why is it that when they have been included, for example, Spinraza, they're the only type who have to fit a criteria before they can have treatment? Is there any more to say on that, or do you think we've kind of covered this already? Yeah. Okay, great. Well, we've covered all the planned activities of the webinar. I think Dermot's going to flash up any questions that may or may not have come in. There we go. Benjamin Symes, question for Fiona, please. Will some of those eligibility criteria be around deciding how to prioritize children for the gene therapy?
Yes, that's a very good question. And I think Francesco's response and his comparison to the vaccine programme is exactly the right one here, is that it won't be possible to treat all children on day one. And some of the work we've been doing is around prioritising the treatment of children. So, yes, we have been doing some of that work in advance so that we can share that with the national MDT. So, again, they're not starting from a blank page, albeit that no doubt they'll want to make their own refinements.
Great, thank you. Any others, Dermot? We got any more questions coming in? Yep. can type 1 currently on Spinraza get Zolgensma? I think sort of covered that to a degree, haven't we? Obviously, once Zolgensma is able to be delivered. So I think, we probably have said that that's a yes. Any other thoughts on that one from anyone?
I suppose just to emphasise that, part of the standard of care is to be able to start eligible treatment on Spinraza as soon as possible. And that I think Francesco mentioned that as well. So, some of those children who the National MDT will assess will be on Spinraza and possibly on risdiplam. Mostly Spinraza, I think.
I think it's fair to say that there will be a number of criteria, won't there, that determine how children are prioritised, and it's very unlikely that being treated with Spinraza will preclude you from being considered for gene therapy if other factors such as your age and disease severity suggest that you would benefit from Zolgensma.
I think that I would just only add, I will repeat myself and saying, time is the essence, and the good news, I think, is that there are drugs, even if it wasn't immediately Zolgensma next week, but there are drugs that are effective, that can be accessed rapidly. And then that, I think, is the priority, is not to be fixated with one or the other or the third or the fourth, but is to start any of these effective treatment as soon as possible. And then that allows to get into a rational mode, keeping your child in the best possible health, without being concerned that if he or she was on Spinraza or on risdiplam, will not be eligible for Zolgensma. So that is a concern you shouldn't have. Okay.
See if any other. Yep, we've got Laura Starks. What is a realistic timescale from now as to when this treatment will be ready to be actually given to children at the chosen centres who have met the criteria? I think Fiona was saying hopefully May would be the plan.
Yeah, so we've asked the 4 successful centres to confirm that they would be able to treat, they're in a position to treat a child in May.
Yeah, okay, thank you. That covers that one off. And yeah,
I suppose it's,
so I
was just going to say, but just reiterating what we've said, is that whilst you need to be able to treat a child in May, that doesn't mean that everybody who would be deemed to be eligible for treatment is going to be treated in May. There's going to be a process.
Yeah, as Francesco said, with the vaccination programme, it didn't all happen on day one. Yeah. Okay. I think there was another question flashed up from Benjamin. Question for Anne-Marie, please. What is the best advice for parents to help ensure that children are less vulnerable to illnesses that might preclude them from having the treatment?
I mean, I think that, the standards of care that we work to for children and infants with SMA type 1 are there to try and keep children as well as possible and to support them from some of the challenges that you face when you have SMA type 1. And that is making sure that you're in a centre where you can have care for your appropriate ventilation support, thinking, if necessary, thinking about effective management of infections, effective secretion clearance. It's making sure that we've got good nutritional support for children, that they're able to safely get the nutrition they need. And that might mean that they need some kind of enteral feeding, potentially with a nasogastric tube or possibly with a gastrostomy, and that they've got attention to their postural care and management with appropriate physiotherapy, and that families are in a centre where they've got kind of access to the expertise that they need, or and everyone's working together in the best interest to deliver that standard of care. So it's very difficult to say, what an individual family should do or not do to prevent their child getting an infection, because children are born into families with other siblings, and it's about individual families working in a system that they feel comfortable with, that allows them the best possible quality of life. But I think if we follow the standards of care, then we're doing the best we can to try and keep children as well as possible until they can benefit from these therapies that we're talking about.
Great, thank you for that, Anne-Marie. And there'll be lots of information on the SMA UK website, or the support services team can help answer questions or connect with appropriate health professionals as well, for anyone that maybe has more specific questions to their circumstances. So Sandra saying, why is there a waiting time of 120 days after Spinraza? My son is 7 months old. He is due Spinraza 26th of May. Will he get it? Anyone want to take to that?
I'm not sure I quite understand. Is it a clinical question or is it a...
Can we just put the question up
Yeah,
again?
I think we have the question up, yeah. So why is there a waiting time of 120 days after Spinraza? Does that first line make sense to any of you, that the 120 days waiting time?
Is that in reference to the gap between the maintenance doses of Spinraza being every 4 months? Or,
yes, that's true.
Or is it that is there something that is there some concern about the possibility of having I'm not aware of a restriction personally, but Francesco probably knows more than me, between a dose of Spinraza and a potential dose of Zolgensma. But
no, I think that the to the best of my knowledge, there is not such a 120 days after Spinraza to receive the AAV gene therapy. I think that the antisense oligonucleotide will remain in the system for quite a while, and while common sense will suggest not to do the two procedures just the same day or in very, very close association, just because this is not the way we do things, and also for the children. But and I think the national MDT will devise more clear guidelines, and I don't want to put a number there, but I think 120 days is there is no written nowhere that must be 120 days, and it will be much shorter than that, very likely.
Yeah. Okay, thank you for that. Sophie, is there a time limit between last Spinraza dose and when Zolgensma can be administered, which I think we've just covered off in the last part there from Francesco?
Well, the only thing I can say is that it's not going to be 120 days.
Okay. Is there any connection between the viral vector in Zolgensma and the viral vector in the AstraZeneca COVID vaccine? Could one affect the other?
No, they only have a similar name, because one is an adenoviral vector and the other is an adeno-associated viral vector, but they are, although the names look similar, they're like not even cats and dogs, they're even more different than that one. So no, there is no problem, and no, and even if, Anne-Marie mentioned that the only risk in that we cannot control very well is that if an individual child already has had exposure to an AAV, the risk is age dependent, and is, for people of my age, I think maybe 40-50% of the people of my age would be positive for AAV9. In the first few months or years of life, this number will be much smaller. It's probably closer to maybe 10% or something like that. So if somebody is positive for AAV, that's a problem. But adenoviral, they can be positive for adenovirus. They can get adenovirals that will be a kind of cold-like disease, and this will not preclude them from AAV at all.
Thank you. Will the AAV9 antibody test be done before referral to infusion centres? Lots of nodding of the head there.
Yeah.
I think that's the aspiration, because we want to bring the time down between kind of identifying a potential child who benefit and being able to deliver the treatment, and that, as we've discussed, is a key question that needs to be answered.
Okay, thank you. Good. Any other questions coming in, Dermot? So from Benjamin, even though a child might not have the treatment sooner, would we still be informed that their acceptance has happened and the treatment is booked in, as it were, or is it an individual referral panel decision treatment process for each child?
Yeah, so Benjamin, that's a really good question. What I'm thinking at the moment, and the discussions we've had so far, is that there will be an assessment discussion, then there might be a prioritisation discussion, as we've talked a bit like the sort of vaccine rollout, and then a discussion about when the child might have treatment. So at the moment, our thoughts are that the assessments would be done sooner rather than later on, if you like, the sort of prevalent children. So that's our current thought, but that's evolving. But it's a really good question.
Anything from Anne-Marie or Francesco on that one? No. Okay. Harley, hi, my son is type 1, 26 months old. Will he be excluded because of his age? I think we said that age isn't the only variable or the only factor. Any thoughts on 26 months old as a specific age? No. Okay.
I'm not answering this one because I'm not the doctor here.
I think Francesco's probably got the greatest experience, so I'm going to defer to him on this.
Yeah, I think also I should just jump in and say that it's very hard to make specific, predictions and decisions based on individual cases. I think that's something we should put out there more generally. But I mean, if you've got a thought on that as an age, by all means say it. But yeah, I'm happy to push that question back a bit if it's too specific.
I think again the right answer is it depends, but and there are multiple things, and it's a bit difficult to say clearly. If you follow what we are saying, the older the patient, the risk benefit will change. And so, I mean, you can start from the end when I said this treatment is not a good idea for people with type 3 SMA. And this is because given intravenously in somebody who is 7 years old, as an example, is never been tried, the weight of this individual will make the viral load really excessive. And therefore, at that end, is very easy to say that's not possible. I think coming towards the left of that end, I think that it will require discussion. And I think, again, there will be the role of the MDT will be important. The other area that I think is important for people to realize is that this is a rapidly changing area. We get information every week on efficacy, on safety, and I don't think that it is sensible to say that we have every single piece of information that will allow to stratify every single patient in the next 20 years. I think we are learning, and we know very well who are the patients in whom maximum benefit can be achieved immediately. And I think that's a good way to start.
Yeah, thank you for that. Okay, we'll take this one. I think we'll start to draw to a close, really. Rose is asking, what would be the ideal weight range for kids who are potential candidates for receiving Zolgensma? We're getting quite hard to give specific answers here, aren't we, really? But I think probably come back to Francesco's last point that there's obviously, whether it's age or weight, there's sort of the extremes of both directions, and then in the middle there are conversations that are going to need to take place with every individual's health practitioner. If anyone wants to add something, that's great. Anne-Marie.
I think it's really important that we do our best to keep every individual infant and child as healthy as possible, and children need to have a weight that allows them to maintain their sort of capacity to deal with infection, to grow and develop normally. So one of the things I would be really concerned about is if we left families thinking that they had to restrict the weight of their child in order to fulfill the criteria, because as we've said, making decisions about who's going to benefit from treatment is not going to be about a single parameter. It's not going to just revolve around your age or your weight, but it is going to be important that the child is able to tolerate the treatment and is as well as possible. And so I would just encourage families to follow sensible advice and guidance and continue to work with their treatment centres to keep their child as well as possible.
Thank you for that, Anne-Marie. Great. Well, I'd say we're gonna draw to a close. As I said as well already, I think all of the information you've been able to share has been really, really valuable and helpful for the community. Totally understand where individuals are looking for individual case answers, but it sounds like there's definitely things are moving and more information is coming out every week. So everyone in the community, just do keep an eye on the SMA UK social media and website, and just keep up on the latest news. Really, any other sort of questions that you're really keen to be heard and have answered, again, do get in touch with the charity and they'll do their utmost to give you the right answers. So yeah, really just to pull it to a close, thank you again to Fiona, Anne-Marie and Francesco for your time and information. That was very, very helpful. And we'll see everyone again for the next webinar coming really soon. Take care for now. Bye-bye.
Thank you. Take care.
Bye.